And I would like to introduce our next panel, and then we'll have a special announcement at the end of this panel. So our moderator for this panel is Dr. Camille Clare. So Dr. Clare, if you would take over. Thank you.
Thanks, everyone, for hanging around for the last panel session of the day. How many have enjoyed the colloquium so far? So I'm an OBGYN by profession, so I know very little about these topics other than its relationship to pregnancy. So I hope that the panelists can enlighten us, especially to the issues of health policy and cost. And if Dr. Howell is here, he can make his way up to the panel right now. I have a couple of slides. If they can bring up the slides for me. Dr. Ted Jones, who's the OBGYN section chair, was going to do a brief presentation on Zika. Where is the advance? How to advance my slides? Okay, here. But Dr. Mitchell asked me to just talk to you a couple of minutes about Zika and its special considerations for pregnancy. So I'll do that just as moderator's privilege before the panelists gets up and speak. So basically Zika is, as we know, a single-strand RNA virus. You have to bring this much closer to me so I can see it. In the Flaviviridae family of viruses, thank you. It's spread to people mostly through mosquito-infected bites. It's usually, the symptoms are fairly mild, very nonspecific, of a fever, rash, joint pain, and conjunctivitis. The symptoms are usually seen in about 1 in 5 people. In some cases, our sexually transmission has been seen in those partners who've had sex with their pregnant partners. So it's usually spread from patients, pregnant women, to their fetuses. It's been linked to a serious birth defect called microcephaly, and I'll show you some pictures of that. And it's really a public health emergency that we need to be aware of. It's affected a large representative population in the 2 areas that my region covers, which is Puerto Rico and the U.S. Virgin Islands, and black and brown people, primarily in South America. So it's something that affects all of us worldwide. So this is what microcephaly looks like. The babies, is this a pointer? Okay, the head is, this is the normal size head, and this is a microcephalic head, and it really affects brain development. So it's something that we should really be aware of, and it's really an emergency and a serious issue for these patients. So in terms of diagnosis, we have to consider any other viral illnesses, including dengue fever and chikungunya. Yeah, I said that right. Some of the features, patient clinical features, have to determine what are their features, what are the places and dates of travel, and what the activities they've undergone. The laboratory diagnosis is more clear now. It's basically serum or plasma levels to detect the virus. So, and that's available to us as providers, so we have to be aware of that. There's no specific treatment available other than supportive care. NSAIDs have been used for arthralgias, and it's really a public health notification issue. So, and I'm sure Dr. Caine will speak a little bit, hopefully, to that issue as an infectious disease specialist a little bit in her talk, as she's going to talk about HIV. So these are the areas that are affected by the Zika infection. It is known in Jamaica. Our region is going to be going to Jamaica with Region 2. Don't let that interfere with your ability to travel there unless you're pregnant, because I still want to see all of you in Jamaica in May 26th to the 30th. Plug. And these are the CDC recommendations. Mostly the most important issue has to do with looking and seeing what areas are affected in terms of your travel plans if you're pregnant or you're attempting a pregnancy. If there are any questions, please refer to the CDC or your OB providers and colleagues. ACOG, which is the American College of Obstetricians and Gynecologists, have really good guidelines for that. We basically hear about Zika on a daily basis, if not more than one time a day. So, that information is available. And in terms of sexual partners, those who are having sex with their pregnant partners probably should use condoms or abstain during the period of time of their pregnancy. So I won't have too much time for questions because I don't want to take away from the panel discussion too much on that, but we'll be happy to talk about that a little bit more in the OBGYN section at the National Convention. Another plug, July 31st to August 3rd. I've been doing good with my plugs. So our first speaker this evening is going to be talking to us about sickle cell disease. Dr. Thompson is a hematology section head at the Ann and Robert Laurie Children's Hospital of Chicago, and she's also the professor of pediatrics at Northwestern University Feinberg School of Medicine. And she's going to talk to us about sickle cell disease.
Good afternoon. I'd like to thank Dr. Mitchell for the invitation to speak with you about sickle cell disease. This is actually a remarkably exciting time to talk about sickle cell. There are some new data in terms of looking at this disease very differently and some opportunities that we hope will involve collaborations with members of the NMA. These are my disclosures. So when we talk about sickle cell disease, I suspect that many in the room have some familiarity with this condition, either because of during medical school or in the course of your practice. But sickle cell has really become a lifespan disease, with the very earliest manifestations of it being within the first year of life, with pain episodes, infections, and splenic sequestration. Additional manifestations that come in during the early school age years, not only pain, but also acute chest syndrome and brain injuries of a variety in sickle cell disease. Later on in the school, moving on, we continue to see pain in acute chest, but also retinopathy, gallstones, and priapism, and finally in adults seeing pulmonary hypertension, sickle lung disease, sickle kidney disease, and cardiac dysfunction that are all related to this one monogenic disorder. We've made progress in sickle cell disease. There are challenges, but we believe that there are also opportunities. Certainly, the most important measure in sickle cell disease has been universal screening, which is now available across the United States. And also now there are a number of evidence-based early interventions that we know will save lives and prevent complications. But there are challenges. We know that there is limited data on whether children are actually fully benefiting from these. So a perfect example of this is that it's quite clear that penicillin prophylaxis saves lives in children. Yet I cannot tell you how many 3-year-olds with sickle cell actually get penicillin, that we at the current time lack the surveillance to actually ask us fundamental things about how are we doing with taking care of our children. Also, hydroxyurea, which is the only FDA-approved drug for sickle cell disease, which in and of itself is problematic. But even with that being available, we know that it's underutilized. There are some opportunities. We think that there are opportunities to expand long-term newborn screening follow-up, but again, to help us understand how our children are doing. We want to be sure that there's access to high-quality, evidence-based medical care, and I'll certainly discuss with you some new guidelines that represent that, as well as opportunities for new disease-modifying interventions. In the adults, progress certainly is that 95% of American children with sickle cell disease will survive to their 18th birthday. The challenges are that there's increased healthcare utilization in young adults between the ages of 18 and 30, not only in our emergency rooms, but also on the inpatient service. And because of that, it is not clear that we are continuing to extend the lifespan. Certainly the last large screen in the United States showed that the average lifespan for men with sickle cell disease was 42, for women was 48. For SC disease, it was 62 and 68. But having said that, that was in 1994. There has not actually been a large-scale surveillance done since then. There are smaller studies that suggest that we actually may be losing ground and that, in fact, the lifespan may be getting shorter. Hydroxyurea, again, seems to be underutilized in the adult population. Our opportunities come from the NHLBI evidence-based guidelines, which were released in September of 2014. And I'll discuss it in a minute, as well as the sickle cell research priorities. I should mention that it didn't come up as part of my introduction, but I'm currently serving as the vice president for the American Society of Hematology and will be the president of the world's largest association for blood disorders in 2018. So I'll be talking a little bit about ASH, and we're looking forward to ASH collaborating with NMA, which is going to be one of my take-home points at the end of my talk. But the new sickle cell disease guidelines, we know, really need to get out there. So this was an NIH-supported systematic review across, everything that we know about sickle cell disease to ask the question, what do we know and what we don't know, and how strong is the evidence for what we're recommending? Based on that, the guidelines were prepared and include areas on health maintenance, managing acute complications, hydroxyurea, transfusions, and managing chronic complications. How many of you are aware of these sickle cell guidelines? That's phenomenal, because I got to tell you, often in a room, everyone says, "Oh, that's nice," but really, it is not out there. And so, one of our real challenges is dissemination and implementation of these guidelines. In the course of doing these guidelines, though, it was also fairly clear that we lack evidence for many of the things that have been recommended, and so we would consider those to be opportunities to actually fill these knowledge gaps. Some of the gaps I suspect many in the room are well aware of, and one of them are in health maintenance. We know that many sickle cell patients, in fact, get very, very little health maintenance, immunizations, safety assessments, and then routine non-sickle cell related care. Challenges also occur with management of comorbidity. Certainly that sickle cell patients are frequently having to manage more than one disease, including asthma and hypertension, and also mental health services, either directly or indirectly related to having sickle cell disease, and the paucity of services. And then finally, I think many of us are well aware that the number of adult providers for sickle cell disease has been wanting, and that clearly as more of our children survive, the opportunities are going to be who do we turn to actually take care of them. As I mentioned, the American Society of Hematology represents over 15,000 physicians, researchers, and trainees from around the world who study and treat blood disorders and blood diseases. These are just among, and I'm certainly not going to touch on all of them, but these are some of the initiatives that have been launched by ASH, specifically focused on sickle cell disease. We have a sickle cell task force. I'm going to touch on some of the research priorities, the guidelines and the conversion of those to pocket guides, which are now available on your cell phone. Our policy on sickle cell trait, and I'll touch a little bit on sickle cell trait and research in that area. Our collaboration with the CDC and the Sickle Cell Disease Association of America, and then finally our call to action. Some of our priorities include novel therapies. As I mentioned, that the only approved drug in the United States is hydroxyurea. I think that is just absolutely shameful, that a disease that is so prevalent only has a single indication among approved drugs. What are the opportunities for novel agents that are promising, either ones that are because of rational drug development or known drugs that actually can be repurposed, and which, if any of these agents, can be combined with hydroxyurea in sickle cell patients? I think it's fine to talk about disease management, but certainly today is a day where we can talk about curing sickle cell disease, and so being able to understand where the opportunities are to actually look at curative therapies. Just want to show you a couple of examples of breakthroughs that are coming out even just this year. So this was just published this last month in The Lancet. I think many of you are well aware that sickle cell disease is the #1 cause of strokes in children, and that it is absolutely devastating. It robs these children not only of the use of their limbs, but their ability to learn, and that it typically occurs during the school-age years. We've known for some time that transcranial Doppler, which is an ultrasound test that should be done annually, will actually identify children at highest risk. Yet we know that the vast majority of children in the United States do not get TCDs done annually. When your TCD is abnormal, we know from, again, research studies that the way to prevent strokes is to actually transfuse children. And when I say transfuse them, I mean transfusing them monthly, and as best we can tell, that needed to be for a lifetime. That's still the case for those who have actually had strokes. We do not know of another way to actually prevent secondary strokes other than transfusing. But for kids who have abnormal TCDs, these are school-age kids who otherwise are in classrooms, seem to be okay, but they carry a risk. Is there something that we can do beside transfusions? And so this was actually the Twitch study, which was reported out and published in The Lancet this past month. Multi-center trial, not only in the United States, but also internationally. And the results is a non-inferiority study, but showed for the first time that families do have an option. So this is a non-inferiority study, and what we can now tell parents is that if you cannot, if for whatever reason transfusions definitely is not something that you and your family can embrace, you can safely protect your child by using hydroxyurea. There are other new therapies that are in the pipeline. So for one of the first things that, for the first time, certainly in my career, there are actually multiple pharmaceutical agencies that actually are interested in looking at sickle cell disease and have drugs in development for sickle cell disease. The GMI 1070 trial has been completed and clearly has some benefit in people who have have sickle cell disease. The same for MST 188. That trial is just completing, and we hope will go to the last patient on that trial was just treated last month. I'm pleased to say that my site had that very last patient, but this was an international trial that was very successful in enrolling completely, and so I think we're looking forward to seeing what those results show us. There are also preclinical things that are being done in mice, but again, I think it still reflects that there is a pipeline that is rich, that is open, but that we need to push in order to get pharma to actually embrace sickle cell disease and the opportunities there. Curative therapies, transplantation has been there for some time. It is not offered to many families. This trial was presented at the ASH meeting in December of 2015. This is over 1,000 patients combining the U.S. experience with Africa, with Europe, with South America, over 1,000 patients with a 94% overall disease-free survival for children with sickle cell disease. So clearly, I certainly do transplants as well as part of my work. There aren't many diseases where we have rates better than this. So to say that 95% of people will survive this, by and large, if you survive transplant, you are cured of sickle cell disease. Having said that, I think gene therapy is here, the patient, we don't have to look for there being a sibling donor. We know that most of us won't have a sibling donor. The patient serves as their own donor, and using a lentiviral vector, the beta globin gene, which is the gene that's abnormal in sickle cell, is transferred into the patient's cells and integrates permanently, and then their cells are given back to them. The first patient was completed in France and is doing well. The U.S. trials have begun. My second patient's in the hospital right now. He's just beginning to engraft. But I think the bottom line is that for families who want to consider state-of-the-art genetic correction, these are things that we have at our fingertips that we need to be more aware of and that we need to actually encourage, at least on a research basis. Clearly, enhancing pain research, we think, is something that's absolutely critical, and there are opportunities to collaborate with some of our neurobiology colleagues and others in that area. I would be remiss if I didn't talk about sickle cell trait. There are 3 to 4 million Americans with sickle cell trait. There are hundreds of millions of people with sickle cell trait worldwide that results just from the inheritance of a single sickle gene. They do not have sickle cell disease, but of course they're at risk for having children with sickle cell disease. And there has been, I'm sure many of you have seen, mostly played out in the lay media, some associations with it. But by and large, we think that for most people with sickle cell trait, there are no health risks, but certainly we have seen these rare cases. We think that it's been so important to educate the public about this, and so the ASH has collaborated with SCDAA and the CDC to actually come up with with a toolkit. And so really, please feel free to go onto the CDC's website. The toolkit is almost complete, but we've provided information that are very colorful and that are very, very specific for sickle cell trait, for athletic participation, for a variety of different concerns that people have had. Hemoglobin A1Cs, are they reliable in people with sickle cell trait? What about eye injuries? There are a number of things that people continue to have questions about. Can I just have something that's very simple about genetic counseling? All of these are one-pagers for families that can just be printed off of the CDC website. We think that there are still questions, though, that need to be answered. Does sickle cell trait increase your risk for sudden death with vigorous exercise? That is a question that we do not know the answer to, despite the NCAA mandate, which, by the way, ASH opposes. Does sickle cell trait increase your risk of strokes, blood clots, or heart disease or kidney disease? There's a small amount of evidence to suggest that perhaps it does, but again, deserves more research. Does the inheritance of this trait interact with other things that actually may cause you to be at risk for complications? We think that these are all things that really need to be looked at closely. And so that leads me to our call for action. We actually are looking to actually collaborate with a variety of stakeholders, and we had a really vigorous meeting. We've had several meetings over the course of 2015. Our interests have really have been simplified down into 3 areas. We're interested in looking at access to care. We're looking at research and refining what the research interests are, and we're interested in looking at global opportunities with global stakeholders. I think many of us are accustomed to looking at things like the World Health Organization maps that tell us about where diseases are occurring in the globe, but I think this is a more important one, and this is actually a cartogram where the world map is actually distorted to actually give you a clear indication of where the burden really is. So the United States is sort of the sliver up in the corner, but those huge areas are Nigeria, DRC, and India. It's so important to recognize that basic health interventions will make all the difference in these areas, and that we think by 2050, with really basic health interventions, that over 5 million newborns with sickle cell disease could be saved. So in summary, we have unprecedented opportunities to advance research and provide high-quality medical care for patients with sickle cell disease. We hope that part of that will be the widespread adoption and implementation of the new NHLBI guidelines to provide a framework for optimizing care. We've identified that there are knowledge gaps, and we hope that those represent opportunities for research and improvements in care, but that without ongoing and in many areas increased investment, this progress will be lost. And with that, I'll stop. Thank you.
Thank you very much. Our next speaker to transition on to another topic that's exciting and new in several areas of development, hepatitis C. Dr. Charles Howell is going to come up. He's the professor and chair of the Department of Medicine at Howard University and Howard University Hospital. He's going to talk to us about hepatitis C.
Well, good afternoon. Thank you, Dr. Clare. First, let me thank Dr. Mitchell and the organizers of this meeting for inviting me to participate. It's an honor to be invited to discuss the issue of hepatitis C, an ongoing crisis. As I thought about the topic, I thought, well, perhaps for those of you who've been following the advances and all of the hoopla about hepatitis C in the media, you might think that that topic is somewhat anachronistic, but I think it's very timely in that hepatitis C continues to be a crisis in the African American and other underserved and minority communities. So over the next few minutes, what I'll do is focus on three areas in regard to hepatitis C. First, I'll provide some data and information on the epidemiological trends with an emphasis on, again, the issues in African Americans and Hispanics. Then I'll talk about some of the opportunities in terms of controlling the future morbidity and mortality related to hepatitis C. And in that area, I'll also focus on some of the advances that have taken place in treatment. And then lastly, we'll spend a little time on some of the challenges that have emerged, notably the issues of access around the pricing and cost of treatment. Let's see here. Okay, so many of you may be familiar with some of this information, but the data from the NHANES study in 1999 and 2002 suggested that somewhere between 3 to 4 million persons have been infected with hepatitis C in the United States. And as a result of that, the sheer prevalence, it makes hepatitis C the most common blood-borne infection in this country, followed in decreasing order by HIV and chronic and hepatitis B. It is the main etiology for liver cirrhosis and primary hepatocellular carcinoma, and the indication for a significant percentage of the liver transplants that take place in this country. The mortality has been increasing, primarily related to the increasing numbers of persons who've been infected with hepatitis C for more than 20 years when cirrhosis and its complications began to develop. And this has been associated with significant growth and increase in healthcare costs, and it continues to rise as we speak. So it's also been well established that the burden of hepatitis C is greater in African Americans compared to Caucasians or whites. And for instance, in the NHANES study, it was found or estimated that about 3% of African Americans have been infected with hepatitis C compared to 1.5% of whites. During this time period, African Americans accounted for about 12 to 13% of the population, but about 22% of the HCV cases in the U.S. And the highest prevalence of hepatitis C actually was found in African Americans between the ages of 40 and 49 years, of whom 9% were infected, compared to about 4% for whites. The the true numbers or precise numbers of patients infected with hepatitis C in the United States is not known, primarily because of limitations in the NHANES methodology. It only samples non-institutionalized individuals, and we know that, for instance, about 20% of the prison population have hepatitis C. So that's about, so 20% of 2 million is about 400,000 in and of itself. And it does not sample homeless populations, which are known to have an increased prevalence of hepatitis C. So you'll see estimates, liberal estimates, of somewhere between 5 to 8 million persons infected. And so based on the NHANES data, I have and others have estimated that there may be somewhere between 1.5 to 2 million African Americans infected with the hepatitis C virus in the United States. Now, most of the information that I'm presenting here is focused on the U.S. population. It should be recognized that that this is a big problem globally, and that somewhere close to 200 million persons are infected with hepatitis C globally. And so some of the issues that we talk about here as it relates to access are, just, you multiply that by 100-fold in the resource-limited countries. So the NHANES study actually estimated that about 6.5% of Hispanics were infected with hepatitis C. However, information on other Hispanic populations was not available because of the small numbers. And so I thought I would just share some information. And actually, that 6.5%, at least in the NHANES study, did not indicate an increased burden in Hispanics, at least from 1999 to 2002. However, the early NHANES study did show actually a higher prevalence in Hispanics. So this just gives you some indication of some of the limitations of NHANES. But anyway, this Hispanic community study of Latinos, actually took an opportunity, made an effort to address this issue by studying close to 12,000 Hispanics in 4 cities in the United States. And interesting, you can't see that very well. I can't see it from here. But the point is that what was found, that the prevalence of hepatitis C varied in this population by state of residence or by city of residence and country of origin or area of origin. And so I think it's important to recognize that, for instance, Puerto Ricans from the Bronx and Chicago had basically the highest prevalence of hepatitis C infections. In the Bronx, about 15%, and in Chicago, about 5%. Particularly, this is from with a higher prevalence in men. And then other populations include Dominicans living in the Bronx, as well as Mexican Americans living in San Diego and perhaps in Chicago. So it's something to keep in mind as we're seeing patients and actually functioning and operating on limited data, to recognize that that these populations also carry an increased burden of hepatitis C and therefore should receive adequate medical attention. So it's also known that we also know that the clinical outcomes of hepatitis C are worse in African Americans and Hispanics. And so this includes both the higher incidence and mortality rates for primary hepatocellular carcinoma, as well as higher death rates, HCV-related mortality rates. So it's important to recognize that the incidence of primary liver cancer, or HCC as abbreviated on this slide, has been increasing over the last several decades. And chronic hepatitis C is responsible for probably 30 to 50% of those cases based on retrospective studies. Interestingly, African Americans and Hispanics are more likely to have hepatitis C as an etiology for the liver disease leading to primary liver cancer than whites. Also, we know that the mortality rate, for this particular cancer actually is about equal to the incidence rate, primarily because most persons are presenting with in the late stages of the disease when it's not amenable to resection. So we know that, and so that's been seen as well. But interestingly, the most rapid rise in the incidence of hepatocellular carcinoma has been seen in African Americans and Hispanics. And there are some other disparities regarding a tumor stage of presentation and access to care that I won't address right now. So what about mortality rates? This is a slide that's based on National Center for Health Statistic data, in terms of mortality rates relating to hepatitis C, and this is 1995 to 2004. The point is that consistent with the higher prevalence of hepatitis C in African Americans or blacks and Hispanics, what one sees is a higher rate, death rates, at least for the most part throughout this study period, but a faster rise in blacks and Hispanics compared to whites. You also may know that this trend has continued in subsequent years, and that in 2007, for the first time, more patients died from hepatitis C-related liver disease than HIV, and that trend has continued. So now, I mean, having basically provided some information on the epidemiological trends, I thought I would turn now to some of the opportunities that have developed and that are available, and that, if utilized maximally, have the potential to control the hepatitis C problem in the population, and to narrow, significantly reduce the health disparities that have been pointed out. Before I say that, though, I think it's important also, I would like to note, to emphasize that the trends that are current trends and estimates and projections are that the number of patients with end-stage liver disease and primary hepatocellular carcinoma relating to hepatitis C will double between now and the next 10 years, and that'll be associated with a tripling in death rates and mortality, up to about 35,000 annually. That is assuming that we don't do anything else, that we don't do anything differently in terms of, and that the treatments are not readily available and accessible to the populations who need them. So first of all, I think you've heard, you probably can't miss it if you watch any television or listen to the radio, all of the attention that's been paid to the advances in treatment efficacy by hepatitis C drug development. And so what we're talking about is the ability to cure hepatitis C, not simply to suppress it and to suppress it long term, as is the goal of therapy for HIV and hepatitis B, but to cure infection with a finite course of therapy, and for the most part, 8 to 12 weeks of oral therapy, at least at the most recent times. But it's important to recognize that, from where we've come in terms of treatment advances. And what we're showing here is this graph is the cure rates that have been achieved with hepatitis C therapy starting in 1991 and extending up to the present time. I also have taken the opportunity to show the results, or to compare the results and outcomes of treatment in African Americans and whites, because for most of the time there was a significant racial disparity. Anyway, so the point is that in 1991, interferon became the first treatment approved for chronic hepatitis C in the United States, and actually for the next for the next almost 20 years, interferon remained a significant and essential component of the treatment for this infection. However, in subsequent times, it was combined with ribavirin, which is a weak inhibitor of the hepatitis C virus polymerase. But you will note that, particularly for hepatitis C genotype 1, which is the most common type of hepatitis C virus in the U.S., and it actually accounts for about 90% of the hepatitis C infections in African Americans, that the cure rate was about half that for whites. That's up to about 2002. And then in 2011, we had the first FDA approval of a new class of treatments called direct-acting antiviral therapies. That is, these are treatments that are targeting hepatitis C viral proteins that are necessary and required for its propagation and replication in vivo. And so, I don't know if we can. Okay, good. So anyway, and that was the approval of the protease inhibitor, which again had to be used in combination with interferon and ribavirin. And one of the goals, and so what you'll know in comparison to the previous bar for both populations is that there was a significant increase in cure rates with the most dramatic increase being in African Americans. But it's interferon-based, and therefore, and we know African Americans don't respond as well to that therapy. But again, shortly after the development of these first categories of hepatitis C direct-acting antiviral treatments, we had the development of sofosbuvir, which is a first-in-class hepatitis C virus nucleoside polymerase inhibitor. And then, even though it was used in combination with interferon, what you see is that quickly it actually essentially eliminated the rest of the disparity, the lower disparity in response rates between blacks and whites. And then coming shortly after that in 2014 was the approval of an all-oral regimen of interferon, of direct-acting antiviral treatments that are free of interferon. And so for the first time, we have treatments that are able to cure greater than 90% of the cases of hepatitis C in patients regardless of race and other clinical characteristics. And therefore, this actually has provided an enormous promise in terms of the ability to control the infection. Why? Because we know that if we can achieve a cure of hepatitis C, that there are many clinical benefits, including improvements in liver biopsy, a decreased incidence of end-stage liver disease, decreased need for liver transplantation, and the decrease in both liver-related and all-cause mortality rates. So it's significant. I think I got a little ahead of myself, but the point is that this shows a schematic of the hepatitis C virus genome. And so basically, these squares here basically identifies the targets, the viral targets for the direct-acting antiviral treatments. The protease, the NS5 replication complex, the NS5B nucleoside, polymerase, as well as the, in this case, non-nucleoside inhibitors for the polymerase. So based on these developments and advances, the American Association for Study of Liver Disease and Infectious Diseases Society of America have recommended antiviral treatment for all patients with chronic hepatitis C infection, except for those with limited life expectancy due to non-hepatic causes. Now, the association actually kind of, I think, responded to some extent to the restrictions that had been had begun to occur around the cost by saying that if resources are limited, that the ability to treat all infected patients immediately, limit the ability to treat all infected patients as recommended, that treatment should be given and extended to those at greatest risk for disease complications before treating those with less advanced disease. The next, how are we doing? Okay, so, all right. So we're doing fine, okay, for time. So anyway, so the next major opportunity, I think, is the whole issue of screening and identification of patients and getting them into care. It's important, one of the observations that has been made is that in the more recent NHANES study, only about 50% of patients who were infected with hepatitis C were aware of that they were infected. And in fact, in some studies, up to 75% of persons are just not aware that they may be infected. But one of the significant observations that has come forth is the fact that 3/4 of the patients with chronic Hep C were born between 1945 and 1965, this so-called baby boom generation. And so recognizing that in an attempt to identify patients based on risk factors for hepatitis C transmission had not worked, in 2012, the CDC recommended that patients who were born in this cohort should undergo one-time screening for hepatitis C using the hepatitis C antibody, and that those who are ultimately identified to be infected should be referred for care and treatment if indicated. And as of this year, this would be all individuals between the ages of 51 and 71 years old. So one of the things that we can do, obviously, is to promote this because the majority of patients are in this age group and can be identified with the very sensitive tests that we have. We should continue to ascertain risk in other age groups, but it's not absolutely necessary for the baby boom generation. And the third opportunity I think that has presented itself is the Affordable Care Act of 2010. You all know that the ultimate goal and the projections were that 30 million persons who were outside of healthcare that didn't have health insurance would actually now gain access through participation. I think we're on the way to meeting that goal. And then there are some other beneficial effects as it relates to disorders like hepatitis C. That is, private health plans. The screening recommendations were endorsed by the U.S. Preventive Services Task Force. And so as a result of that, it requires that health plans provide this preventive service, the hepatitis C screening, without cost sharing, which is a significant barrier for many persons. And then, of course, the Medicaid expansion, which is a significant component in the states that have taken advantage of it. And then the prohibition against excluding persons based on pre-existing conditions are all issues that are faced by hepatitis C patients as well as other patients with other disorders. But what has emerged really in the light, against this, in the setting of these very exciting advances that have occurred is a challenge which I don't think I anticipated would become as prominent as it has, and that is the issue of the prices for these drugs, and the impact they've had on access, and we'll review some of that. So you've probably heard about some of this because sofosbuvir was introduced when it was introduced as a first-in-class. A 12-week course was priced at $84,000, so it's about $1,000 per pill. That was in 2013. And then following shortly thereafter, simepravir, which was a pill that has to be used, an antiviral, a protease inhibitor that has to be used in combination with sofosbuvir for $60,000. So it would be the two of those together. You're talking about $140,000. And then subsequent to that, in 2014, this combination, ladipizvir, sofosbuvir, for $94,000 for 12 weeks. And then 2014, another combination that's, you're seeing a little drop, $83,000. And then most recently, this combination of elbasvir, grazoprevir for $55,000 for a 12-week course. So in response to that, many of and I'm going to move forward, many of the state Medicaid agencies began to put restrictions on who could receive these medicines. And so this is a study that actually addressed and looked at the practices of state Medicaid, state and DC, as it relates to hepatitis C treatment. And 75% of them were limiting sofosbuvir only to the patients with advanced fibrosis, F3, F4. 25% required the co-infected population to be on antiretroviral therapies and to have suppressed HIV RNA. Another 2/3 of them restricted treatment based on the prescriber. So, and in fact, many of them, I think even DC, continue to require that patients be evaluated by gastroenterologists, hepatologists, or infectious diseases professional. And then there are other requirements as it relates to drug and alcohol use. And some of these practices and recommendations and policies are not consistent with the recommendations for the professional societies. And so it's an issue. And as you can imagine, the population that would be, for instance, the hepatitis C population, there's a increased, it's associated with less education. I mean, there's a higher percentage of persons with less than high school education, and there's a higher percentage who are poor. That is less than 2 times the poverty level, the federal poverty level in terms of income. There's been a lot of activity on the Hill and also in the public concerning this cost issue. And I'm sorry, we don't really have enough time to focus on that. But it's important to note that that the Center for Medicare Services has actually has noticed this and actually issued some directives to the state Medicaid agencies, as well as to the to the manufacturers about their responsibility for making these treatments accessible. And hopefully that's going to lead to some improvements in terms of what we're seeing. So in conclusion, chronic hepatitis C is the main cause for liver-related morbidity and mortality in the U.S. It's twice as prevalent in African Americans and Hispanics and associated with worse clinical outcomes. Full implementation of the birth cohort and risk-based screening and better access to hepatitis C treatments could decrease future suffering, and as well as decreasing the racial and ethnic disparities in hepatitis C outcomes that we've discussed. Thank you.
And our final speaker, who's also equally provocative in her discussion on HIV disease, Dr. Virginia Caine. She is the HIV and infectious disease subsection co-chair of the NMA. She also serves on the National HRSA CDC Committee on HIV, hepatitis, and sexually transmitted diseases, and she's the associate professor of medicine in the infectious disease division at the Indiana University. And I know she's been watching the clock and knows our time limits, but she'll be equally provocative and on time.
Thanks. I'm delighted to be the last speaker to try to wake you up, before you go and leave the room. So it's always my pleasure here. So, and I want to excuse the folks on this side of the room because looking at that monitor, I may not always look over here as much as I should when I'm talking. So, get my attention in relation to that. And I just think this is an amazing conference. I've just been delighted with the discussion with everybody, and the speakers have just to be among these dynamic speakers and colleagues. I'm just outdone. Well, this is my favorite subject. It's what I sleep and breathe every day. And I'm going to touch a little bit on Dr. Howell's hepatitis C because I think this is really important. In a lot of these smaller communities, rural areas, they don't have access to what we call HIV RYAN services. They may only have one doctor there, and they're lucky if there's even a hospital there. And guess what happened in Indiana? The unthinkable, and that is we had an outbreak of HIV that happened in Scott County, and we had 188 cases of HIV that was identified, and we suspect there's maybe as many as 300 to 400 that we just haven't been able to identify yet. This particular county ranks 92nd in terms of health outcomes. We look at our social indicators and life expectancy. Now, why am I telling you about this outbreak? It did happen into a white communication, but it can happen anywhere. Georgia, Pennsylvania, just any place, Arkansas. And the interesting thing about this is that they used a drug called Ipana, but high poverty, almost a fifth of them, unemployed, 22% had no high school degree, and of course there's no insurance down there. They used this particular pain medication called Ipana, where they could crumble. It's supposed to be resistant, but they crumbled it up, and able to inject it. And the interesting piece about this, they had injections anywhere from 4 to 15 times in a day. And each of those injections had anywhere from 1 to 6 partners. So let's think about it. If you injected 15 times and you had maybe as many as 6 partners, how many people did you infect in a day, with this injection? Okay. And this is a generational thing. This is like a socialization. So this went from generations, grandparents down to their children, and even their teenagers being involved as a socialization because, they didn't have things like, going to bowling. I think they had one bowling ball bowling ball place, or, so not a lot of things for people to do and whatever. So it's a form of socialization. But of the of the ones who were HIV infected, 95% had a co-infection were hepatitis C. Now, reason why this is an important point, if we went by CDC's guidelines of who to screen for Hep C, we would have missed every single one of them for Hep C. Wouldn't have happened. So when we're having our acute hepatitis outbreaks, they are occurring more times than not in a younger generation, not the baby boomers. Guys, we're just too old and too tired now, so it's not happening with us. I just have to tell you, it's the younger generation. So I want you to be conscious of asking them to screen them, because otherwise we're going to miss a lot of hepatitis C. And there's a lot of heroin addiction going on across this country, and so we don't ask, we're going to miss this. Now, blacks continue to disproportionately, of all the diagnoses of HIV infection from 2010 to 2014, you can see we're at least 20% higher in the diagnosis of HIV compared to any other racial ethnic group there. And when we look at over the 225,000 cases between 2010 and 2014, African Americans made up 45% of all those cases. And black African American women, of the women who were HIV infected, we made up over 60% of the cases. And no surprise that when it comes to our children, over 60% of the children less than age 13 were infected. But look at that third bullet. Of the African Americans who became infected, 64 of those infections were attributed to heterosexual contact. What am I saying now? We have this misnomer that the only ones getting infected now with this HIV epidemic is just MSMs, but I want you to look at that number now. So in 2014, of all the diagnoses of HIV, 44% were in African Americans. Now, this is a wonderful slide. Is any one of you have any grandchildren or children going to college or planning to go to college? Anyone out there? Okay, now, I want to direct your attention to the state of Montana. If there's ever a place that you want to send your children to, and you don't have to worry about them becoming HIV infected, don't even have to worry about the sex now, but not becoming HIV infected, I want to put in a plug for Montana. All right? Okay. But as you can see, for African Americans, our rate of diagnosis of HIV infection are in those states that are the greatest in the pink. And now, you're not going to believe this. This is the highest rate of HIV infection, followed by Washington, D.C. at 101.5 per 100,000 becoming infected with HIV. But isn't that South Dakota? Okay, so now why would you think South Dakota has the third highest rate for HIV infection? Military base? I'm going to let you come. That's the question y'all going to ask me when I get to my question and answer, okay? But I want you to look at this now, all right? So the other thing is when we break it down by geographic region, just those bars that are in the pink shows the African American diagnosis. So we see that the highest rate of HIV infection is occurring in the South. The second highest is occurring in the Northeast. And look at this. The West is the next, and then the Midwest. I want you to thank yours truly for standing on the highway in Indiana, keeping out HIV infection from the Midwest. All right. Now, when we break it down by the special subpopulation groups based on mode of transmission, we do see that the highest rate with the black MSMs of all the cases in 2014, they made up the majority, 11,000 cases. If we add the Hispanic MSMs at 7,000, that's nearly almost 20,000 cases of the 40,000 cases we saw with HIV. Followed by the whitest MSMs in the second category, black women in the fourth category, nearly almost 5,000 cases a year, black women continue to get infected with HIV infection. The Latino woman next in the category, with the white female being the least infected and impacted on all of this. Now, you know, HIV is just not a United States, it's global. And I want to continue to remind people that Sub-Sahara Africa is the most severely impacted with this HIV. We have 31 million folks that are infected with HIV in the world. And of that 31 million, 25 million of them are in Africa. In the United States, we only have 1.2 million cases, with about 12.8% of people not realizing they're uninfected, but 25 million in Sub-Saharan Africa. So in 1999, I show you this slide because in 1999, 1 in 3 women and 1 in 7 men ages 15 to 24 had HIV infection in 1999 in Botswana. I'm going to fast forward. Let's see, sorry, I hit the wrong button. To show that when you've got free medications and you've got access to medical care, you can make a substantial difference. This is a wonderful success story in Botswana that they set this ambitious goal that they said at least of all of their HIV patients in Botswana, we're going to get 73% their viral suppression suppressed for HIV to really cut down this epidemic. Well, this year in Boston, at our largest conference we have on HIV/AIDS in the world, Botswana Studies, through a collaboration with Harvard, was able to show that approximately 70% of all the HIV patients in Botswana were on medication and had fully suppressed viral replication. That is just unheard of. That's incredible leadership from the Botswana nation. What an incredible leadership. We need to get them over here. Help us out, okay? But it's just remarkable because the majority of the people knew about their HIV status and were able to get something done. Now, our risk for HIV infection in the U.S. is dipping, but the racial gaps continues to be wide. And you know, back in 2004, 1 in every 78 people were at risk for HIV. Now it's like 1 in 99 are at risk for HIV. But if we look at it based on race, we still have a big gap related to this. So the lifetime risk for someone getting HIV, if you're male, is 1 in 62. If you're female, 1 in 221. But if we looked at it just broken down by race, guess what? If you're a black male, 1 in 20 is at risk for getting HIV in this country during their lifetime. For females, it's 1 in 48. Now, if you're a Hispanic male, it's 1 in 48. And if you're a Latino female, it's 1 in 227. And look who's got the best risk factor for not getting HIV, 1 in 132 for a white male, and for a female, 1 in 880. I need a blood transfusion from some white female to lower my risk for getting HIV. Now, but here's the really frightening data that we have to show. If we looked at it in the subgroup of black men, what their risk is, if you were a black male having sex with the same gender, another male, the risk for acquiring HIV is 1 in 2. Let me tell you this. 1 in 2. If you are a black male who is having sex with another black male in the United States, your risk for acquiring HIV is 1 in 2. If you're Hispanic male, it's 1 in 4, okay? And if you're white male and you're in MSM, it's 1 in 11. Now, you know over time, that concentration of HIV infection is only going to get greater, so that number is even going to be worse. So that is very, very frightening for us. We also know that based on what state you live in, Your risk for chronic HIV overall in Georgia is 1 in 51. North Dakota, I didn't say South Dakota. North Dakota is 1 in 670 in North Dakota, but the lifetime risk, if you're in Washington, D.C., is 1 in 13. Okay, so that's not so good either. Now, the other great news and success, this is no longer a life-threatening condition that's become like a chronic disease. And we've made substantial progress with our meds. And the progress that we've shown is that now over 50% of those patients now are over 50 years of age. You know, they're living longer, so they're not dying with the HIV infection. But in a study done by Kaiser Permanente, highlighted the fact that if you were a 20-year-old now, you're expected to live another almost 50 years, so that now, if you're an HIV infected at age 20, you're going to live to almost 70 years of age. And whereas you were a 20-year-old and you didn't have HIV, you're expected to live until about 83 years of age. So there's still that 13-year gap there being HIV infected. But this was better than the gap back in the early 2000s where the gap was 26 years. So we were HIV infected, we were losing 26 years of our life. It does make a difference, too, that if you're able to start your HIV treatment early, with your CD4 counts at least 500 or higher, you can even reduce that gap to where you're only losing maybe 8 years and not 13 years as long as you start your treatment early. Now, one other thing that I think that, of course, what complicates our cases who are HIV, especially in African Americans, is we have these other factors, these social determinants that impacts our risk factors for being life-threatening. And that is your poverty, the stigmatization, meaning that you may delay going in to get your treatment because of the fear related to the HIV, and then our other comorbidities, hypertension, renal disease, can also impact and shorten our lives. Now, would you believe this? Women are less likely to take their antiretroviral therapy than men. I just never would have believed that, okay? I do understand that black people are less likely than Hispanics or white people to take their antiretroviral drugs, but I thought women had it, maybe they're too much of a caregiver. I'm going to go into this a little bit more clearly. Women make up 1/4 of all the people living with HIV, and most of the women are HIV infected, or much of the women are black or Latinos who make up the bulk of those HIV cases. And this was Dr. Linda Beard from CDC who revealed these study findings. And what the data has shown is that more men than women take retroviral therapy, 91% of men compared to 85% of women, and that black people are less likely to be on antiviral therapy, 86% compared to 92% of white people who take the antiretroviral drugs. But what's of significance is that there's almost the viral suppression when you're even taking the medication. Men do a better job of making sure their viruses are suppressed, meaning they're more compliant in taking their medications on a regular basis than it appears as though women. And it may mean that women have so many other responsibilities or so busy that it may impact their ability to be able to be as compliant as the men. But we found that black women and even white women are more likely to discontinue their antiretroviral drugs than black men or white men. And the reasons that women were asked why they were not taking their retroviral therapy, what was the answer? Most said it was based on the advice of their provider. Yes, I'm going to need that. Don't you look at that bottom line. When they asked the participants why they were not taking their retroviral therapy, most said it was based on advice from their providers, Dr. Beer explained. Now, unfortunately, they didn't delve any closer to find out why the provider told them that, but it's a huge burden and responsibility on us that we need to get folks on this antiretroviral therapy. 31% of women are not on it who should be on it. 26% of men are not on it who should be on it. But in general, we know that HIV is saving lives. And so this is a call to action. We have to better understand why women are less likely to take their HIV therapy. And there's no reason now in 2014 for any person living with HIV to be denied or to abstain from starting antiretroviral therapy. So we need to look at how we enhance their HIV literacy and use gender-specific linkage to care and HIV treatment initiation interventions in order to make a difference. I'm going to end my slide by just saying that one of the newest innovative treatment things that's going to really knock this HIV infection off the charts. You know when you stick your needle, stick your hand accidentally on someone who's HIV infected, and you know you have to take that post-exposure prophylaxis within 72 hours, and you got to be on the HIV medicines for 28 days. It reduced you from getting or acquiring HIV by 81%. So they said, wow, this is so effective. Why don't we think about pre-prophylaxis HIV prevention? And so there's now one little pill, and it's a tenofovir and itracitabine combination tablet you can take once a day that will prevent you getting an HIV infection in about 92% of the people if you're on this pill. So if you are, with a strong recommendation that if you are an MSM patient, you should be taking this just one pill a day. It will reduce your risk for HIV infection by 92%. Now, I have to honestly tell you, it seems like the STD rates may go up, okay, because they're not worried about HIV now. But it cuts drastically their HIV. Now, the cost is $1,425. That's a monthly cost. And so the annual cost is about $18,000. And so it's great in those states that have Medicaid expansion. But the company is now saying, who produces this particular drug, that unless you are in a Medicaid expansion state, they're not going to be providing patient assistance for that particular drug. So you know we have our work cut out for us, and a large study has shown that our patients will take this. Historically, it's been difficult for people to be compliant, but they've done a large study involving Black investigators in this study that have shown that if it's offered to them, they will take it, and they do very well. And so I just end by saying we really have to be conscious of all these medication costs. We have to advocate to make sure that people have access to HIV medicines. We have to advocate for our hepatitis drugs. I don't want to wait until I've got stage 2 liver disease from my Hep C, before I can get my hepatitis C treatment. I don't feel I should have to damage my liver before I receive my medication. Something just don't seem right with that. And one last point I'll make. Remember, that medication was $18,000 a year, that one tablet a day. Now, so phosphorvir was $85,000. I think that's right, Charles?
12 weeks.
Huh?
84.
It's $84,000.
For 12 weeks.
For 12 weeks, yes, but think about my $18,000 a year. So what's that? 5 times 20 is about $100,000. So, but now if I could have cured my HIV, I don't have to worry about any more paying. It's $100,000 for 5 years, but I've got the lifetime of that person. Versus, you think about it in regard to Hep C, I'm curing it in 12 weeks. I don't have to worry about the other 40 years I got to treat him with if I couldn't cure it. Thank you.
Thank you so much. The time is really short, but if anyone has a really burning question, you'll be the one with the burning question. If someone can get the mic over to her, and then the panelists will be available after to talk to you. So if you could stand and say your question until the microphone makes its way over here.
Good afternoon. I'm Sonia Johns, president of Old Dominion Medical Society in Virginia, and I would like Dr. Howell to discuss a segment of the population that is not represented in your hepatitis C, and that is those of incarcerated, which is a significant proportion of HIV and Hep C, but primarily Hep C.
Yeah, I did refer to it in my talk, but I mean, the point is that about 20% of the incarcerated population, I think, is estimated to be infected with Hep C. And if you look at the population that was in there for injecting drug use, it'll be higher. So it is a major population, major issue in terms of issues. And in fact, there's been attention to managing Hep C in that population. It's an important population. I've seen some recent. In fact, as you probably know, many of the prison systems will treat patients for Hep C depending upon the duration of the sentence. If you're going to be. And it's probably variable between states. I would grant you that. I saw something recent where it was about the cost effectiveness of treatment in the incarcerated population, and so I think that obviously people who are incarcerated deserve to get the medical care that's appropriate for what for the conditions that they have. I'm not sure if I'm addressing your question.
Wondering about that statistic, because I inherit about 50 or so offenders. I work at a female institution, and we have transfers about 50 offenders per month. And I want to say anywhere between 40 and 60, because if you come at 10 per week or 12 per week, either 4 to 6 out of 10 have Hep C.
Yeah, I wouldn't be surprised. I mean, depending on the population you're looking at, recognizing that that the war on drugs. I mean, basically, it's interesting that the way we are dealing with addiction at the current time, in the outbreaks that you referred to, and this is hepatitis C, has been seen. The incidence has been going up because of cases of young whites in mostly suburban or rural settings, like in Appalachia, who've been abusing prescription opioids and then getting Hep C on top of that. I mean, the war on drugs took the approach of incarcerating people for substance abuse issues. Now, of course, in this era, I mean, I think we've evolved in our thinking, but it's interesting that in dealing with this population, this suburban white population, the focus is completely different. It's focused on rehabilitation, and so I think that's appropriate. But I think the issue is our prison population swelled under this aggressive war on drugs, which was basically targeted primarily brown and black people, right. And so there are a number of people working in the incarcerated population. I salute you for your work there.
I'm sorry.
I salute you for your work in the incarcerated population.
Thank you.
Okay, was Dr. Mitchell wanted to come up to make her announcement, or?
If you guys more question about Dr. Mitchell.
Okay, last message.
Quick one. I never got the answer to why South Dakota has such a high rate.
Oh. They're the second fastest growing black population in the country. They've more than doubled their population in the last 10 years.
And the reason for that is they had an oil boom. There's been the domestic oil industry but no longer is that the case? Is that right? It's not that?
That happens in North Dakota.
Oh, is that right? So what's the draw to South Dakota?
Use the microphone. Use the microphone.
The Africans have been moved to South Dakota by the State Department when they came to the U.S. So they migrated from Africa and they've been placed in South Dakota.
Minnesota is the Somali.
So I'd like to thank you very much to panelists for your provocative discussion, and we'll invite Dr. Mitchell back up.
South Dakota, North Dakota. I mean, you know, it's like